Thank you, Bob, and good morning, everyone. It's a pleasure to be back here at the center. The center and Columbia campus has contributed so much to our response to the epidemic, and certainly Anka and Zina starting the center have made incredible contributions, with Zina really being the first person to talk about microbicides as a means of women-controlled prevention. And the field it's really been exciting over the last few decades to see what we've learned, and also daunting and humbling to know how much we still need to learn. So a lot to say, too little time. I want to, for those who are not as familiar, I want to just sort of talk about my little microenvironment about where most of the work is done. Talk about the new paradigm, which is no surprise to people here. Talk about some of the lessons from Crough, because I understand from Bob that not everyone here had attended, and there certainly are a number of headlines and things that may inform the set of issues. And really, part of the thesis of this talk is, we're pigeonholed into HIV, but I think really the work we're doing is really about sexual health and really trying to broaden the conversation and the intended and unintended consequences of some of the particularly antiretroviral and immunologic interventions. I think we have to think more broadly about what are some of the other impacts. Certainly also focusing on the diversity of the different populations, focusing on health disparities. I want to talk a little bit about providers, and then really end up really establishing why the NIH's new priorities. A lot of people in this center, a lot of my collaborators who are behavioral social scientists, thought that they were very negative about the role of social behavioral science. I think it's the opposite. I think there's the primacy. It just means that the new work has to be integrated in a much more effective way. So Fenway Health is a federally qualified community health center. It wasn't started as an LGBT health center. It was started as a neighborhood health center, part of the activist movement in Boston where community health centers were initiated. So it was started in 1971. I started working there in 1980 in a voluntary capacity doing STD testing. It's now grown into a much larger facility with a full spectrum of services available. At this point now, as of 2016, there are about 30,000 people who get primary care at Fenway. That's our main center at the facility. About 700 people work there. About 100 people work in the Institute, which I'll mention in a minute. And we ask people about sexual orientation, gender identity. Not everybody fills that field out, but you can see that one of the great things about working at Fenway is it's a very diverse population, so there is a focus on LGBT health and a focus on HIV, about 2,000 HIV-infected people in care, but a lot of people who are not HIV-infected and a lot of people who are not LGBT, which allows us to compare within the same facility. About 15 years ago, we recruited a colleague who several people here know, Judy Bradford, to broaden our work because we had been responding to the HIV/AIDS crisis, and so the studies we were doing involved epidemiologists, involved social behavioral scientists, and clinical trials, but we realized there are a lot of other health disparities and needs for a lot of other people in the community that were not HIV focused. So the idea was to create sort of an institute within the health center. So the programs that were not focused on primary care, behavioral health, clinical service, direct clinical services really were sort of embedded in the institute. A lot of our work are with the networks, partner in crime here in the HPTN Magda. Sovietsk is here, a number of the other networks we've been involved in, but we've also increasingly been involved in a lot of work using electronic databases, and I'd be interested as I talk to people here at the center today, the extent to which you're going in that direction, because I think this is certainly the wave of the future in terms of working with big data, because some of the questions we're going to have to address are not amenable to clinical trials just because of the enormity of the sample size and some of the subtleties we want to understand. So what's the new paradigm? The new paradigm is this primacy of antiretrovirals. And the reason for that, there are really two streams. Studies like HPTN 052, which recruited HIV discordant couples, showed that earlier initiation of treatment was beneficial. For several years, we were talking about treatment as prevention. Some people actually pushed back and said that really reinforces a vector of disease kind of mentality if you're only treating people so that they don't infect others. But really in the last year or so, we have increased evidence from the START study and the Temprano study in West Africa that starting treatment independent of CD4 count is beneficial for the individual. So the two things really come together, and WHO guidance as well as US Public Health Service guidance now all says as soon as people know their status and they are ready to initiate treatment, they should start treatment for their own benefit and for the benefit of their partners. One of the questions that HPTN 052 did not address was how robust is this idea of treatment as prevention in MSM couples? Because we were actually a pilot site for HPTN 052. Very hard to enroll couples in the US back about 10 years ago when the study started, because people who were infected didn't have equipoise. They weren't going to be willing to be randomized. They either wanted to start treatment early or wanted to defer treatment. So there were very few MSM couples enrolled in HPTN 052, less than 50 out of the 1,750 couples. But Andrew Grulich and colleagues at the University of New South Wales started a study in Australia. We're able to expand it to Brazil and to Thailand now, and they're following HIV discordant MSM couples. And so far, the preliminary data look very promising. So CLAI, condomless anal intercourse. So when the couples engage in condomless anal intercourse with the infected partner's viral load being less than 200 copies, no transmissions were seen. They had more than 5,600 acts that they observed. So 0, but the confidence interval you can see goes to 4.6. So they've expanded the study and extended the study to see if they see any transmissions occurring. But this study and another study in Europe called the Partner Study, which enrolls heterosexual and homosexual couples, so far no transmissions when people are virologically suppressed. But the other finding from the study, the opposite attract study, is protection from whom? And the point is non-monogamy is common. So these are couples who both signed informed consent to come into the study together, and you can see in Australia, almost half of the couples had outside relationships, and in Australia more so than the other sites, almost a little more than a quarter of the couples engaged in condomless anal sex with outside partners. And we saw this in HPTN 052 with heterosexual couples, that even if a couple is committed enough to both be in a study together and understand the challenges of transmission, in HPTN 052, more than a third of the transmissions that occurred were from outside partners. The central labs led by Sue Eshelman was able to virologically sequence outside transmissions. So this is part of the rationale for PrEP. We can't just rely on treating primary infected partners as a means of stopping the epidemic. And if we take the cascade and kind of disaggregate it, and the CDC did this last year, you can see that we have more than 1 million people living with HIV in the US at the present time. We have this large group of people, more than half of the epidemic, who have been diagnosed but are not stably maintained in care. They are not virologically suppressed. And those individuals are associated with almost 2/3 of new HIV infections. And then we have the number of people who have not been diagnosed, including those who are newly infected, associated with another 30% of infections. So these are individuals who may not disclose their status to their partners, and this is part of the rationale for PrEP in settings like the US. Until we really are able to have much better metrics in terms of the number of people who are virologically suppressed, we have to think about also antiretroviral prophylaxis for those who are at high risk of HIV, because relying on treatment as prevention is not sufficient. Now, Bob Remian is leading a study with Chris Bauer that'll be getting underway in the next couple of weeks, which is trying to look at how do you optimize getting individuals in those two groups diagnosed, established, and stably into care. So that's HPTN 078, and hopefully that study will give us insights how we can do a better job in this population. But in the meantime, this is why we need to think about PrEP. So this is the scorecard. The AVAC report a couple years ago reported on the first suite of trials, and then with Geeta Ramji, I did a review last year. And basically, you can see the effect sizes here. You can see the efficacy, and these data I'm sure are familiar to most people here. And the vast majority of the values show significant decreases in HIV incidence in individuals who are randomized to tenofovir FTC, and in a couple of the studies, tenofovir alone. But there are the studies of the young women in Africa, which we can certainly talk about shortly, which did not demonstrate efficacy. But certainly diverse populations, and overall the effect size was beneficial. The other key point is that WHO did a review, a meta-analysis of toxicities. Toxicities were minimal, but they were not non-existent. Again, the current first-generation PrEP that we have, we can't give it to people who have any evidence of renal insufficiency. And there is a bone signal that has not been clinically significant, but still further studies are needed for young people where bone is being elaborated, and we know nothing about older individuals who might be at risk for osteoporosis and long-term effects of tenofovir FTC. But there were presentations at Crough, particularly about the bone signal, that when people stop PrEP, bone normalizes very quickly. But these are things that we have to pay attention to, but overall, quite safe and well tolerated. And this is just a simple plot that says basically the best single predictor of the efficacy in these randomized controlled trials was adherence. Easier said than done, but that's where, again, there's a robust research agenda for behavioral scientists. I want to just highlight one study because this is relevant for some of our discussion about the most recent studies, the RING study. And this is the PROUD study led by Sheena McCormick. So this study was done at genitourinary clinics in the UK. So the first study in men who have sex with men was a study we were part of, the PROUD study. The intent to treat efficacy of tenofovir FTC for PrEP was 44% decrease in HIV incidence. The PROUD study had an 86% decrease in HIV incidence. Similar population, men who have sex with men. IPrEP had an international cohort, mainly recruited in Latin America, but 2 sites in the US, Cape Town, Chiang Mai. But so men who have sex with men, same drugs, tenofovir FTC, but double the effect size. So people wondered when the initial IPrEP study came out, would people be even less adherent in the real world? But actually people were more adherent, at least in the PROUD cohort. The PROUD cohort, the men were told, this will work if you take it. We know that from the earlier studies. You're going to be randomized to either be on a queue and get all the state-of-the-art counseling. You can get post-exposure prophylaxis. You'll have your STDs treated. And within a year, if we see that this is beneficial in the real world, you'll get access to this, but be safe in the meantime. And despite that, their incidence was almost 9% among the individuals, whereas there were only 3 infections among the individuals who were in the immediate group. And 2 of those individuals, they were in the process of becoming acutely HIV infected. One individual misgauged his risk where stopped PrEP and then subsequently had an exposure and became HIV infected, but very powerful. So I think this is very important because it says that context really matters, at least for some populations. The real world effectiveness may exceed the efficacy in an intent to treat analysis. Now, one other cautionary tale from Crough. Some people sort of modeled and said, if you're highly adherent, PrEP is going to be 100% effective. We now know we can't say that anymore. This was a very well characterized case. The plural of the plural of anecdote is not data, so we can't, but it's an important cautionary tale. So this was a man who had sex with men who went on PrEP, was followed in Toronto by a very competent clinic. He came in with some very strange GI symptoms, but his clinician got a history that he had multiple exposures. The patient said that he had been highly adherent to PrEP, but the clinician did work him up for acute HIV infection, sent an RNA, which was positive, and then got a blood specimen right away and sent it to a lab to show that he had levels of tenofovir in his blood that would suggest that he should be protected against HIV. Then they did a genotype on his virus and very highly resistant. So there are strains that may overwhelm the protective benefit of PrEP. This is an extremely rare case. In all the clinical trials, the emergence of resistance was extremely rare, but it certainly is a caveat. It speaks to the need to keep developing new modalities. I certainly don't expect we're going to see huge numbers of this, but I think it is a cautionary tale. So where are we with prevention? So I want to just sort of move into the future and then go back into our real world currently. So we have oral PrEP with WHO recommending this for all key populations, all people at higher risk as of September 2015. We've had 3 vaginal gel studies. The first one, Caprisa 004, showed a 39% decrease HIV incidence. We had 2 studies, Facts and Voice, that did not show the benefit of topical tenofovir gel. This doesn't mean that vaginal gels are not going to be developed further. There's work going on in the city. Betsy Harrell's lab is developing new topicals. So the question is, can we identify something more potent? And again, the behavioral science question is, what will enhance adherence to topical product? There's data presented on rectal gel, which I'll share with you, the largest study to date. Bob had mentioned Alex Carvalho-Dieguez and team were the lead behavioral scientists for this. the 2 vaginal ring studies, and then the future of long-acting injectables, antiretrovirals, and antibodies. And you have Magda here in the room, so I'm not going to cover vaccines today, but certainly that's worth a discussion, and Jintanat also can talk about this. So before we go to new modalities for delivery systems, one question is, can we use other drugs besides tenofovir for PrEP? So Trip Gulick from the city presented a study as protocol co-chair for from 2 of the networks, HPTN and the ACTG, looking at Maraviroc. So this is an entry inhibitor. It's very safe and well tolerated. It's not used a whole lot. We wanted to look at whether Maraviroc regimens might be useful for PrEP, and this was the first foray into non-tenofovir-based regimens. So we looked at, everybody got 3 pills. We looked at Maraviroc alone, Maraviroc plus FTC, Maraviroc plus tenofovir, and the comparator tenofovir plus FTC. And the good news, bad news was that the drug was well tolerated, but so was tenofovir FTC. So adverse events were not uncommon, but they tended to be mild. But it wasn't as if it was so much better tolerated, the Maraviroc regimens, than the tenofovir FTC regimen alone. So the rate of drug discontinuation was relatively low, but similar across the arms. There were 5 HIV infections that occurred in the study, even though this was not a highest risk population. It was a phase 2 study, so the individuals had some level of risk. And what was interesting was that, unfortunately, all 5 seroconversions occurred in individuals who either were assigned to Maraviroc alone or Maraviroc plus tenofovir. Now, in 4 of the cases, the drug levels at the time that the people became infected were 0 or very close to 0. So these were individuals who happened to be non-adherent. There's no evidence that adverse events were the reasons that they were non-adherent. So this is sort of the bad luck. Would have expected to be more evenly distributed across the arms, but certainly nothing saying that tenofovir doesn't work in that setting. The one that is getting further workup is that there was one individual who was assigned to Maraviroc alone who did have a level that you would expect to be protective. There are 2 types of HIV that can affect cells. There's the CCR5 that affects monocyte macrophages more, and the other, the CXCR4, which preferentially affects T lymphocytes. This was sequenced, and this was not found to be one affecting the CXCR4, which might be a way to escape Maraviroc. So we don't have a good answer why Maraviroc did not work in that case. So that's 1 out of 100 in that arm where there was this breakthrough, but certainly it raises questions. So we don't know whether Maraviroc is going to be further developed for use as PrEP by itself or in combination, but certainly none of the infections in the Maraviroc plus FTC, which might be a very well tolerated regimen. So sometimes things that are, that there's a cloud one day, there may be reasons why things later on come back and get further developed, but clearly a lot of the excitement is on other modalities. So one of the areas that got the most attention, and Bob attended an NIH consultation last week, and he may comment when we have discussion about this. So there were 2 vaginal ring studies that were presented at the retrovirus conference. These vaginal rings contained Dapivirine and NNRTI. The idea of the ring was that it could be inserted and removed around coitus if that was preferred, but the intent was to leave it in as much as possible, and that the amount of drug available would last a month, so these rings could be replaced on a monthly basis. So DPV is Dapivirine, PLC is placebo, and basically there was protection seen in both studies. The ASPIRE study, funded by the NIH, had a pre-specified condition because in some of the earlier studies, because some of the sites had lower levels of adherence, they said if a site at a certain point doesn't meet a threshold for adherence, we can remove it from the analysis and we can over-enroll at the other sites. So you have analysis from all 15 sites that were initially started in ASPIRE and then the 13 where adherence was higher. If you include everybody who started in the study, the protective efficacy was 27%, which was statistically significant. If you include just the sites that had a reasonable level of adherence, it was 37%. Another parallel study by the developer, an international partnership for microbicides, nonprofit organization, the efficacy was 31%. So this is overall. There was a pre-specified analysis to look at women over the age of 21 because some of the earlier studies showed lower adherence in younger women. And you can see the efficacy in the ASPIRE study went up to 56% in that setting. And if you look at over 25, it goes even higher into the high 60s. So you have this phenomenon of something that works, but clearly the population that might benefit the most are not showing statistically significant benefit. So clearly there's a need for further studies to see what can be done to enhance adherence, because very much like the IPREX proud kind of situation, if you are now told this will work, but you have to use it, and these are the characteristics of use, and you identify a subpopulation who are motivated to use the product, it could potentially be highly beneficial. I want to move on to rectal microbicides. So MTN-017 was a study that enrolled 400 men who have sex with men and transgender women. The study enrolled at 4 sites in the US, in Peru, in South Africa, and in 2 sites in Thailand. And basically the take-homes, each of the participants was asked to, for a 2-month period, to either use a daily rectal gel that was tenofovir-based, or use the gel pericoitally, or take tenofovir FTC every day on a daily basis. And basically the rectal gel was found to be safe in this population, so that was good news. What was interesting was that men who were asked to use the gel on a daily basis, this was the least acceptable condition. So in other words, if you weren't having sex that day, people did not particularly like having the gel in their rectum. The feeling was not acceptable. But the pericoital gel use, the characteristics of that, people felt that that was an acceptable alternative to daily pill use. But it was a surprise to me as one of the investigators on the study, the extent to which pills were still highly prized by the individuals. But these data certainly suggest that further evaluation of pericoital rectal gel would be an appropriate study. So the question is, again, what would the study design be? This would obviously have to be a huge study if you're going to have a placebo gel, but then in a high-risk population, the ethics then of not making oral tenofovir FTC available. So these are some of the challenges for the future generation of trials. The next modality I just want to mention very briefly is injectable PrEP. So the data were presented at Crough for Cabotegravir. Cabotegravir is an integrase strand inhibitor. It has very long half-life, very high barrier to resistance. So you can see here in the yellow, based on animal data, the team at V Pharmaceuticals thought that this is a drug that can be given every 12 weeks. So quarterly injections, intramuscular injections would be sufficient. But what they found, the blue line you can see goes below this line here. And this line here is a pre-specified thought of what kind of level you'd like to have to protect people. So this is 4 times a threshold where 90% of HIV isolates would be inhibited, the IC90. And you can see that the blue line goes down below this threshold for a few weeks at a time. So based on these data, the HIV Prevention Trials Network retooled 2 of its protocols, one in men who have sex with men and one in women, to look now at giving the injections every 8 weeks and trying to establish further establishment of safety in the population, because there's the preparation for a study called HPTN-083, which will be a double dummy study. In other words, every participant will be getting injections every 8 weeks and will be asked to take a pill every day. So we'll either be taking active tenofovir FTC and getting placebo injections or getting active Cabotegravir. So this will be a head-to-head trial of injectable PrEP versus oral PrEP. The first study, HPTN-083, will be enrolling 4,500 men who have sex with men and transgender people in the Americas, and in sites in Southern Africa and in Thailand, and possibly other sites in Asia in the next, hopefully opening in the next few months, certainly before the end of the calendar year. And a parallel study in women will be getting underway in Sub-Saharan Africa shortly thereafter. One of the interesting things was that although there were some pain and tenderness at the injection sites, and the pain attendants tended to be a little higher among those who got the active medication than placebo. So the medication, when injected, can be a little bit irritating. Again, this is the construct of theoretical acceptability, so always have to take it with a grain of salt. But the majority of people said that they were satisfied with their treatment, and particularly when they're asked, if this was shown to work, would you continue this as a preventive modality? And the individuals also tended to rate that very highly. So in theory, this is an area where there may be a great deal of interest, but we also have seen in other studies that theoretical acceptability doesn't necessarily translate into adherent behavior. So clearly much more needs to be learned. The last new modality I want to mention before sort of cutting back to how do we use this information in the real world is the whole idea of antibodies for HIV prevention. So everything I've mentioned up until now is using an antiretroviral for prevention, either orally, as a gel, as a ring, or as an injection. But the field is also thinking that maybe immunoprophylaxis may be a very valuable way to think about protecting people against HIV. The rationale for immunoprophylaxis is the following. There are individuals who are living with HIV for many years, long-term non-progressors, who do not have declines in immune function at all. And these individuals, some of these individuals make antibodies that, when the same kinds of antibodies are used in animals, or where the animals are exposed to a retroviral challenge, these antibodies are highly protective. The field of bioengineering has gone to the point where monoclonal antibodies can be readily manufactured. And so with the further characterization of these neutralizing antibodies that are broadly neutralizing, so they're called BNAbs, and improved technology, the thought is, if you can't yet make a vaccine that can be highly protective, can you at least give people an infusion of an antibody that would be highly protective? And this is not a radical approach. The whole idea of passive immunoprophylaxis or immunotherapy has been used for more than 100 years. So there are a number of different viruses that we have hyperimmune globulins and other specific antibodies for. But the one I put in red, RSV, respiratory syncytial virus, it's a virus that causes very severe pneumonia in children, particularly premature or malnourished children. And in this case, for high-risk children in nurseries, this monoclonal has been shown to be highly effective when there are outbreaks of RSV to prevent them from getting sick. So this is sort of proof of concept that this approach can work with these kind of tailored immunoglobulins. So this is certainly a naturally flowing concept. So at the Retrovirus Conference, I was able to present data from a study conducted in the HIV Vaccine Trials Network at 6 sites in the US, including here at Columbia, as well as New York Blood Center downtown. And we found that one of the monoclonal antibodies that was developed by the Vaccine Research Center of the NIH, VRC01, administered intravenously or subcutaneously, was well tolerated. The product-related adverse events were transient and mild. And we looked at various different conditions, and we found that we could see very high levels, whether it was given with a loading dose or whether smaller doses were given subcutaneously every 2 weeks. The one thing we found was that when we gave it every 2 weeks or gave it every month, because of the complexities of people's lives, there were a lot of missed doses. But we still found that if we gave it every 8 weeks, we could find that the vast majority of people, 80%, managed to be at all their visits. So the thought was, if you're going to go forward with an immunoprophylaxis strategy, probably higher doses, less frequent, may be a better way to go. So this has led to the development of 2 parallel studies now that are called the AMP studies. So these are going to be placebo-controlled study looking at a higher dose of the monoclonal antibody and a lower dose of the monoclonal antibody. The first study that hopefully will be getting underway in April, including sites here in New York, will be enrolling 2,700 heterosexual men and transgender people in North and South America. These are all high-risk individuals, so the main entry criteria will be engaging in receptive anal intercourse. There will be a parallel study that will be starting shortly thereafter in 1,500 women in sub-Saharan Africa. And the studies will be permissive for the use of pre-exposure prophylaxis. So individuals will be educated about PrEP and will be offered referral for PrEP for the study. So this is the idea of infusible prevention using monoclonal antibody. So now to dial back to where are we today with all these things on the horizon. So the CDC at the end of last year came up with an estimate of how many people might benefit from pre-exposure prophylaxis today in the United States. And you can see here, based on national probability surveys, about 500,000 men who have sex with men, about a quarter of the number of sexually active MSM they guess in the US. So large number, about little less than a fifth of people who inject drugs, a smaller number. And then a very large number actually of heterosexual adults. And this is one of the most challenging areas because particularly for women, there have been a number of studies, study conducted in the HPTN, the ISIS study, HPTN 064, found that it's very hard to predict which women are HIV infected or at the highest risk for HIV because so much relates to understanding partner characteristics. So you have a large potential pool where within that potential pool, with 45,000 new HIV infections a year, at least 15,000 are among women. But identifying that 15,000, you could say it's disproportionately among women of color, black women, but even so, your denominator then is still 10 million plus individuals. So very hard, big challenge, but clearly there are a lot of people who'd benefit from PrEP who are heterosexual as well as men who have sex with men. So we've done some studies over the past few years looking at who are the early adopters. So we did a survey on Manhunt, one of the social networking sites, in August 2013, repeated in January 2014. Not surprisingly, people, there was some awareness of PrEP and it was increasing over time, but the uptake was really fairly low in that period of time. But it's very interesting to watch the diffusion of innovation because things are clearly changing. One of the other things we did, a graduate student at Harvard School of Public Health, Katie Oldenburg, did a very nice analysis of a multivariable analysis of, so who were the people who were the early adopters? And not surprisingly, more likely to be college educated, perceived vulnerability because they more likely to have had an STI or used post-exposure prophylaxis. But being comfortable talking to their provider about MSM sexual behavior was really important. And a subsequent analysis that Katie did with Mark Hatzenbuehler from this institution, basically we did a map. The Human Rights Campaign has a map about state policies, which states are more affirmative, less affirmative of LGBT individuals. We found that people from the reddest states were less likely to talk to their providers about sex, were less likely to be using PrEP, and we're more likely to be engaging in condomless sex. So clearly a perfect storm and suggesting, again, the need for sort of structural interventions and educating providers as well. What was interesting at Crough, though, was the CDC just did a bunch of web surveys, more recent ones as well. And you can see here the diffusion of innovation, the uptake. So by March 2015, November 2014, March 2015, you can see in the sample, and again, this is not probability surveys, and there's certainly a need for that. This is a convenience sample. But in San Francisco, over 16% of the MSM who responded had used PrEP. New York City, 12%. Washington, D.C. was quite high as well. Then in the next tier are cities like Boston, Chicago, and L.A., much less so in Atlanta and other areas of the U.S. So certainly some suggestion that there's increasing use. In San Francisco, Bob Grant did analysis last year and estimated that about 31% of eligible people were using PrEP. There are questions about the methodology. It's using some of their national probability survey data, NHBS, but maybe on the high side. The other survey said 16%, but clearly I think San Francisco, probably New York are sort of in the lead with other sort of urban centers in blue states following up, but certainly the numbers are increasing. Here in New York City, there were data presented at Crough, and very interesting analysis finding a prevalence about 7.2%, but this goes back to 2013 to 2015. Again, they did analysis of looking factors that were associated with PrEP, not using condoms, multiple partners, a known HIV-infected partner, and having used PEP. So clearly, this is a group of people who tend to be more aware and are starting to be the earlier adopters. What's happening at Fenway, just want to give you some snapshots from the edge for us. This is first just looking at our infected population of individuals, and you can see that the number of people who are initiating treatment within the first year of being diagnosed has gone up from 68% to 97% over the last decade. The virologic suppression rate has gone up to 86% overall, so not quite the 90-90, but getting there. And the median CD4 count at the time of initiation is 464. At the same time, our number of PrEP initiations among high-risk uninfected men has increased dramatically, with 960 initiations in the past year. So we've also tried to look at the top there, it's the number of STDs, and you can see here our bacterial STD rate has increased dramatically as well. Now, the patient population at Fenway has also increased as well, so some of this is a natural increase as the center has grown. But clearly, there are data from this and many other studies now showing increased bacterial STDs along with PrEP. We did a back-of-the-envelope calculation. We had 5 PrEP failures. 2 of the individuals were in the process of becoming acutely infected. So again, speaks to clinicians ruling out acute infection before starting PrEP. So their first antibody test when they came back for PrEP refill was positive, and going back it was clear that they were in the process of being infected. 2 of the individuals misgauged their risk, so they stopped PrEP thinking that they weren't risky. So only 1 person was truly non-adherent in the sense of saying that they had stayed on PrEP, but we went back and checked drug levels, and clearly they were not taking it regularly. So the incidence is substantially less than 1%. We also have a lot of people who are followed in primary care, men who have sex with men, more than 4,000 who are HIV uninfected, and we had almost 100 incident HIV infections just in the clinic population. So if you compare the incidence of people who are not on PrEP with the people who were on PrEP, it's substantially, there's a substantial benefit to being on PrEP. So you have this trade-off, and that's why I wanted to juxtapose these 2 things. More STDs, but clearly HIV protection in the real world. San Francisco Health Department did a demonstration project in San Francisco, Miami, and Washington, D.C., and similarly found high rates of STDs over time. A report in Clinical Infectious Diseases this past fall from Jonathan Volk at Kaiser Permanente also saw in more than 800 patients who were on PrEP, mainly men who have sex with men, no incident HIV infections, high rates of bacterial STDs. And that's why I think we have to reframe chemoprophylaxis as an opportunity around sexual health, because we can't ignore these other infections while promoting PrEP. I want to transition now and talk about health disparities. So the CDC also presented data at Crough about lifetime risk for HIV. So very, very high for men who have sex with men in general, certainly high also for people who continue to inject drugs and don't have access to harm reduction approaches. When we look particularly by race, ethnicity among men who have sex with men, a glaring health disparity among black men who have sex with men, no surprise to anyone in this room. So we really have to think about tailoring PrEP for key populations. So the Adolescent Trials Network has completed 2 studies. They both are looking at young men who have sex with men, looking at whether an individual level intervention or group intervention helps supplement PrEP. The data on the 15 to 17-year-olds is still being analyzed, but Sybil Hosek presented data recently on the 18 to 22-year-olds that I'll share. And then HPTN 073, a very important study in the HPTN led by Daryl Wheeler and Sheldon Fields is also important to note. So in ATN 110, basically the study provided support, randomized the young men to one of 2 of the evidence-based, CDC evidence-based interventions, either many men, many voices, so a group intervention or personal cognitive counseling. But basically the take-home was that there was a number of the men, so this is an N of 200, so about 1/8 discontinued, but very few discontinued because of treatment-related adverse events. There were 4 seroconversions. Now, the N is relatively small, so the confidence interval around the incidence is pretty wide, but even in the setting of PrEP, HIV incidence was over 3%, which says we have to do more, that clearly we need to think about better approaches for young men who have sex with men, because that's still a very high incidence rate. But to put it in context, an earlier study we did in the HPTN 061, among the men less than 30 years of age, HIV incidence was almost 9% in that setting. So there probably still is a benefit of PrEP. This was a non-randomized study, so we can't say how much more of a benefit of PrEP, but clearly we'd like to do better than 3.9% HIV incidence. SEIs were high and continue to be high over time. The good news was that the people who tend to be riskier did tend to report higher levels of adherence, and drug levels corroborated that. But adherence decrease for all participants over time, particularly for young black men who have sex with men. So the idea of how do you boost or how do you reinforce adherence over time, which many people in this room would be very adept at thinking about studies. This is going to be a key research question. HPTN 073. So this was a study, a PrEP demonstration project for young and older black men who have sex with men. The study tried to enroll about 50% of the cohort less than 25 years of age. It succeeded in getting about 40% of the cohort in that age range. The study was conducted in Washington, D.C., North Carolina, Los Angeles. There were a lot of screen outs, and one take home from the study was that a lot of black men who have sex with men, because of alienation from the healthcare system, because of economic disenfranchisement, have a lot of untreated concomitant morbid conditions. So there were high levels of diabetes, high levels of hypertension were found, and renal disease, so those individuals could not avail themselves of PrEP. So it really speaks to getting people into the healthcare system earlier, not just waiting for PrEP. So basically, the study found that the majority of individuals, when offered PrEP, accepted PrEP. What the study offered, and again, it was not a randomized control study, they offered client-centered care coordination. This was developed by LaRon Nelson, and this was basically more than peer navigation, but not a formal MSW, but somebody who had at least a bachelor's degree, who had sort of a crash course in providing sort of empathic motivational interviewing and linkage to services, which was really important part. So the retention rate was really outstanding. There were 225 participants in the study, 92% completed 12 months. Ultimately, PrEP was accepted by 79%, so 69% at the outset and 10% subsequently in the study. Those who used PrEP tended to have more of these client-centered sessions, so suggesting that the sessions were meeting their needs. The people who didn't engage as much with client-centered care coordination were less likely to use PrEP. HIV incidence still was higher than what we would like. 5 out of 178 of the users became HIV infected, so 2.9% incidence. 2 of the individuals who became infected had discontinued PrEP. So from intent to treat, they were in the PrEP group, but they had already stopped PrEP. So 3 people were not adherent on PrEP out of the 5. 3 of the non-users became infected, and that was a much higher incidence, but because these confidence intervals are so wide, we can't say that there was a statistically significant difference, but certainly some suggestion that the PrEP users had some level of protection. So PrEP was acceptable, there's high retention. This seems like a beginning, but it seems like we could iterate it further, so again, an area for further research. One of the last points I want to make is the important role of providers in this whole paradigm. So we need providers to get people tested. Well, unfortunately, the data suggests very low levels of testing. People are still very often not willing to disclose to their providers, and it's sort of don't ask, don't tell. The providers don't ask either. And yet, I'm working with a young infectious disease physician, Doug Krakauer. This is a work on a K Award. And we're looking at barriers to providers talking to their patients about prevention. And this is a survey we did in New England a little over a year ago. You can see more of the red there. So this is New England, very liberal part of the country, and yet, for a number of the providers, there was lack of patient requests, concerns about insurance coverage, but still, a lot of the providers weren't aware of the CDC's guidance around PrEP. They felt that they weren't adequately trained. They felt they had time constraints. So clearly, this is another area for intervention research, is how to motivate providers to get on board with the new paradigm, because this is something where it's not infectious disease specialists at the outset, because these are getting people to actually first be tested for HIV and to do the appropriate triage. So this was a modeling exercise that the CDC also presented at Crough, and they said basically if we don't do anything today with the current trends we have, over the next 5 years, 2015, 2020, we'll have 250,000 new HIV infections. If we increase PrEP use, we can decrease about close to 50,000 of those infections. If we get 85% of the people diagnosed and linked to care, and 60% achieve virologic suppression, fairly modest, we can get this down almost to half of what it would be without doing anything. And if we really achieve the national HIV/AIDS strategy, if we get a larger number of people linked in care and get 80% virologically suppressed, we get even this further benefit. So it's not either or. We really need both approaches if we're going to get maximal traction. And even with this optimistic scenario, still 80,000 new infections over the course of the next 5 years. So we clearly still have a lot of work to be done. So I want to end with 2 or 3 concepts of why this center is so important in this process. So this is work my colleague Steve Safran, very simplistic, IMB kind of model. You want to prevent disease, you have to promote self-efficacy. Problem with promoting condoms, pleasure reduction, peer models play a role. And all of these things blow up with you have depression, anxiety, mental health problems, and substance use. It impacts each one of these variables. So a couple of years ago, I was part of a group that put together a special issue of the Lancet on MSM and the global epidemic. And just 2 slides from that. Basically, not a surprise here. One of the key populations, men who have sex with men, but we could talk about people who inject drugs. We can talk about women, we can talk about a variety of groups of individuals who experience a lot of health disparities, high prevalence of mental health issues. A lot of these are introduction of social norms that create problems, high prevalence of substance use. Clearly, these issues need to be addressed if we're going to be successful with antiretroviral chemoprophylaxis. So this is really my last slide. TasP and PrEP alone are not sufficient. So first thing is interventions to increase testing. Then if people test, they need to be assessed for risk if they're negative. Not everybody needs PrEP. Not everybody needs any of these newer modalities necessarily, but some people do, and we have to figure out the sweet spot of who will benefit from that. For those who test positive, main thing is getting them linked to care and ultimately on a community level and for their own benefit, maintaining virologic suppression, and that involves several steps. And certainly positive prevention plays a role. But the red box is key. We have to address the concomitant issues: depression, substance use, relationship dynamics, and social and structural issues. With that, I just want to thank you all and thank some of the colleagues who informed this talk.